All right, well, I have that it's just a few minutes after 2, so I'll go ahead and keep an eye on the waiting room and keep admitting people, but I want to go ahead and get started. Today, we are lucky to have Dr. Lindsay Shea, who's an associate professor in Leader Policy Analytics and Community Research Program at Drexel. So she's happy to come and share with us some information about her research and what they do, and join partnerships and explore all different kinds of opportunities. So with that, I'm going to go ahead and turn it over to Dr. Shea.
Hello, everyone. Thank you so much for having me. I'm also just very excited about all of your names and your information in the chat. I think that what I'll present to you today is a series of sort of ideas and places that we've started to go with research, but this research really has to figure out how to operate in tandem with communities who are living this every day to be able to make change. And so all of you here that I see in the chat, what an impressive array of professionals who are really digging in on this work right now, maybe literally, and just doing this. I'm so encouraged to be connecting with you and to learn from you as well. I believe our plan is to take questions toward the end, but I will try and build in some pauses. I'm very open to questions as we move along, or ideas if there are comments that you have or ways that you have suggestions for me. I very much hope that this can be more of a dialogue than just a one-way Zoom. Thank you all so much. Okay. We have a few specific objectives for our time together today. We are going to talk about identifying pathways for how Medicaid enrollment happens for youth with intellectual and developmental disabilities. We're going to seek to understand barriers to examining experiences of youth in foster care with intellectual and developmental disabilities, and understand differences among subgroups of youth with IDD in foster care. I've broken the presentation up into a couple of different segments. So some focus on Medicaid and the foster care system. We have some display of work that we've done in Pennsylvania to try and understand the connectedness in this issue, the ways that we might be able to think about this nationally. We have used our data because we have national data. We have cut some fresh West Virginia data that I will be very interested to see if you think it looks right or not. Data can lead us astray sometimes, and it's always helpful to get feedback from the people whose data we are presenting. I have a brief nod to sort of resources and system gaps as I hope a conversation starter for where else we can go in prioritizing places where we need to generate resources and address system gaps. And overall, I hope that we walk away with a shared urgency for the need that these children are in the system now, that you all are doing this work today. You're probably going to have phone calls and emails and home visits and things that you need to handle even by the end of the day today. And that makes all this work all the more important for us to figure out how to move forward. I want to disclose that I received contracting wages from the Commonwealth of Pennsylvania to support state level data and policy decisions. And there's a chance this could impact how I present specific data, and in particular data from Pennsylvania to you. So I just want to be transparent about that disclosure. Throughout the presentation today, I'm going to use some acronyms and some terms that are commonly used in the field of intellectual and developmental disabilities. So when I use IDD, we're talking about intellectual, that's an abbreviation for intellectual and developmental disabilities. This typically is a group of individuals who have autism, intellectual disability, developmental disabilities, and or Down syndrome, because many of these things can co-occur. Doesn't mean that they have only one of them. They could have more than one. And a reason that it's beneficial to talk about IDD broadly is that this is, as one pathway, a major category for how Medicaid systems function to let people in the front door and deliver services to them. I'll also use terminology related to autism that has been in great debate, especially the last few years, in terms of person first versus identity first language. And I will mostly use autistic individuals, as it has been expressed as a desired identity for the self-advocacy community, but acknowledge that there is not consensus in the best way to use these terms. And that referring to children with autism has been expressed as a preference for many caregivers, and that's important to acknowledge as well. I'll also talk about Medicaid, as in medical assistance. I looked it up and it did not seem that West Virginia has a special name for Medicaid. In some cases, it's Badger Care or Medi-Cal. So I hope that that is acceptable, and my research has done me right in what I learned about the Medicaid system in West Virginia. There are important differences between intellectual disability and developmental disability. So we know that developmental disabilities are a general term, excuse me, for a set of conditions that often onset early in life. This is a place and a time where we may see this as children, and they are having developmental flags for not meeting milestones, but that developmental disabilities with and without other specific labels can persist across a lifespan, although they emerge earlier in life. Intellectual disability has a different definition based on some of the clinical and guiding field entities. However, intellectual disability is often diagnosed using standardized tests and identifying a cognitive deficit or challenge, including an IQ at 70 or below, depending on the state, depending on the program. That is our language section of the presentation. So my main area of emphasis is Medicaid, and this is an area that's especially close to my heart. I've focused on Medicaid and Medicaid claims data for all of my career, and I very much would like to emphasize that I hope we can learn from each other today in terms of how West Virginia's system might function relative to the national system. But that understanding the national context matters because it's how we can articulate sets of shared priorities. So why would we focus on Medicaid? There are many people who are focusing on private insurance and other insurers, and there are children who are getting insurance from many different sources. To me, Medicaid really matters in part because of sheer number. So we have 88 million people in general, around 90 million per year enrolled in Medicaid, and that includes nearly 40 million children. It's nationwide. It's also in the US territories in different facets. And that means that when we can implement a change in Medicaid at the national level, at the federal level, that we can make a difference in 40 million children's lives, that we could try and move the lever a little bit or a lot of it for tens of millions of children. And so that creates a specific sort of opportunity. It also helps us as a public health professional when we think about data opportunities. Many of the conditions within intellectual and developmental disabilities, including autism, are still technically defined as rare conditions, which means that they occur less frequently among children. And so we need very, very, very large numbers to be able to look at big groups of children and understand what's happening within them. So Medicaid presents a specific opportunity not only to look at this system and think about this change, but also to let us have enough children where we can understand experiences on a very large scale. Another reason to focus on Medicaid is that there is a tremendous amount of funding that is spent in the Medicaid system for Medicaid enrollees, and we are talking in hundreds of billions of dollars. And when we look at the breakdown of that spending, we know that most of it is spent on individuals who are eligible for Medicaid based on a disability, based on a diagnosis or another type of disability where they meet criteria within their state. So again, the ways that we're able to use this data allow us to look at among almost 90 million enrollees and among almost $600 billion in spending, how can we think about better system efficiency? Are there ways that we could improve care that help to reduce emergencies that can cost more, be more traumatic, be more stressful and difficult to navigate for children, for adults, and for families? How could we seek to do better? So as we look, Medicaid is also always changing. And in particular, the COVID pandemic yielded several big changes for how Medicaid functions. At the onset of COVID, as we saw tremendous amounts of unemployment, there was a differential uptick in Medicaid enrollees among a whole new group of people, many of whom had not had Medicaid previously. And so we can see among children that there were increases at the beginning of the COVID pandemic. And as states have started to unwind or release the rules that allowed people to newly enroll in Medicaid, that we have started to see some reductions back to pre-pandemic levels. That, however, still yields us almost 90 million people a year enrolled in Medicaid and about 40 million children. So the numbers did change. There were fluctuations, but we are going back to an amount that is still similar to what we had seen previously. So I looked at the Medicaid coverage rates across states and thought I would pull out just sort of where we are. We were joking before we opened up the meeting that I'm just a little bit sort of south, or I'm north of you a bit, but there are big differences in how our states operate. And what does that mean for numbers? How does the difference in these rules result in differences in coverage or enrollment of children in Medicaid? So in West Virginia, national numbers indicate that you have about 44.9% of children enrolled in Medicaid. And that's in comparison to other states that are very low. Utah at about 18%, South Dakota about 1/3 of children, Louisiana is a little over half, and New Mexico is 60%. So West Virginia, that's where you're landing relative to many of the other states in terms of distribution. And so this is proportion of children on Medicaid. When we look at numbers, West Virginia has about 163,000 youth on Medicaid relative to some other states that have predominantly rural areas, such as North Dakota. Colorado has about 400,000. Here in Pennsylvania, we've got just over 1 million, and California has more than 3.7 million. So these numbers are helpful as we think about opportunities for change. So why does Medicaid matter within these large groups? What are the numbers for youth with intellectual and developmental disabilities? So the latest tallies, as we look at some of the data even pre-pandemic, if we're seeking stable estimates over time, there are about 5.3 million children with intellectual or developmental disabilities enrolled in Medicaid, and that the majority of the services for these individuals are long-term services and supports that total tens of billions of dollars. And so as we look at what are long-term services and supports, it's a range of services that individuals need across a lifespan, and that these needs can change. An individual may have one need as a teenager that can change dramatically as they start to age into adulthood in terms of the services and supports that help them to avoid institution-based care. We also know that we don't have a single data set where we can observe differences across race, ethnicity, status like rural areas versus urban or suburban, and linguistic characteristics. We know that individuals who can communicate for themselves have very different long-term service and support needs, or maybe different service and support needs from individuals who are able to articulate their needs and their wants. And so this is an important place in which we are at risk for distinct disparities based on data that we have already seen, but hope to understand this better as our data systems continue to grow and improve. Long-term services and supports really run the gamut. So some individuals are getting job training and on-the-job supports to try and get out and be in communities independently. Other individuals are getting supports on activities of everyday living, so getting changed and managing their household. And some people are getting all of it in terms of seeking to support their long-term needs. The biggest distinction for intellectual and developmental disabilities, as we think about how do experiences among youth in this group matter, is that this is a lifespan set of conditions, that these conditions persist across a lifespan for most individuals. And the ways that we can think about and address needs earlier in life are able to set the tone for later in life. They could result in system savings. They could result in better outcomes for these individuals and for families. And that this characteristic of their clinical needs, their support needs, is distinct from other populations. So there's one of my favorite sayings about autism is that if you know one person with autism, you know one person with autism, because we know there's incredible heterogeneity in which individuals with an autism diagnosis may present, that they can look very, very different across individuals. And I think the same applies to Medicaid programs. in that all of our states have some common themes often set by our federal authorities in terms of what are minimum or maximum bars of what can be provided, but that states often operate very differently from each other. So I went on to the Centers for Medicare and Medicaid Services hosts an online list of all Medicaid waivers and authorized programs. And so I searched for all the Medicaid programs and waivers specific to West Virginia. I hope this list looks right. I hope that their list is correct and up to date. I thought it was interesting that there are actually some similarities between Pennsylvania and West Virginia in that you all have some 1915C, which are traditionally fee-for-service Medicaid waivers, but also some other models, so 1915Bs, as well as 1115 waivers that are more recent evolutions in how we think about Medicaid services and supports. So I really applaud this array of waivers, although I think we often in Pennsylvania, at least, are always looking for more ways to provide services. A paper that we released a few years ago sought to understand and map out more clearly the ways that states are using Medicaid to support individuals with intellectual and developmental disabilities, and specifically autism. So one of the activities that we undertook for this paper was to take the number of individuals with IDD and use that to understand how many of the available Medicaid waiver slots are being used in that state. And as we presented the profile of states, so West Virginia, you're sort of right here hovering in the middle around the proportion of individuals who can get available Medicaid waiver slots or programmatic funding. And this is a helpful metric because over time, we can start to understand, are these numbers shifting? Are states generating new programs or deploying different strategies to try and increase the proportion of individuals who can get Medicaid services or supports? In the same paper, we presented, this is called a Sankey figure, and it maps changes over time. So from the early 2000s, when the prevalence of autism was just beginning to increase, through 2015, where there was much more robust national dialogue about autism and the need to generate programs to meet the service and support needs of this group, we saw changes in states. We saw that states added autism-specific waivers. We saw that states added autism and intellectual disability waivers. We saw that they added autism into their intellectual disability waivers. And then there were a subset of states for which there was no change in this period. However, one note that we indicated in this publication was that many of the autism-specific waivers terminated in childhood or early adolescence, so ending by age 12, by age 8. And although early childhood is a key window in which service and supports can make a difference for long-term outcomes for autistic individuals, that this diagnosis is, alongside other IDD diagnoses, one that is present in most cases across a lifespan. And that means that as these waivers are ending, individuals are likely to still need waiver similar services and supports. And how are states going to continue to try and address that need? So as we think back on some of the themes here related to Medicaid as a system and intellectual and developmental disabilities, we know that many individuals with IDD rely upon Medicaid for services, that youth with IDD are in the millions, that the cost for these services, especially for long-term services and supports, is very substantial, tens of billions of dollars when we look at some of the subsets for IDD, that the services that individuals receive and might need vary tremendously, and that states have different approaches that they're taking for how to structure these programs. I was in Massachusetts a few weeks ago, and their system was wildly different from Pennsylvania's, and it was yet another illumination for me on how states have, for decades, taken different paths to try and figure out these complex service and support need issues. Okay, so a key way that we could seek to move forward together is to try and understand how child development entry to or utilization of the foster care system and Medicaid are intertwined. In what ways can we start to potentially disentangle how these three areas are interconnected so that we can look to address differences, disparities, and gaps? So one area that we focus on in intellectual and developmental disabilities in particular is that early childhood has many key developmental milestones, that there are certain things that children, babies even, should be doing that indicate that their milestones are advancing and that their development is keeping pace with what we would expect in a way that would be typically developing. When children are not meeting these milestones, that's how we start to think about flags for potential developmental disabilities, for thinking about autism risk, for thinking about other ways that we may need to intervene. I think one of the challenges related to these developmental milestones, and in particular, some of the ways that we talk about parenting, caregiving, and helping to track and facilitate these milestones can be really challenging. This is a place where I'm a mother of three, including young children in these developmental milestones. It is very difficult for me, even as a professional with 20 years of experience in this field, to monitor all the time. Who's supposed to be doing what, when, and then if they're not, what do you do about it? Who do you call? And how do you make room in your life to figure out how we're going to juggle this difference and how we're going to help support this child? And this can be really demanding as you multiply across children, as we think about family dynamics, and as we think about all the other things that are going on with families and with caregiving. They do not lessen the importance of these developmental windows and tracking them and addressing them, but they do mean that we can acknowledge all the things that are going on among individuals who are trying to figure this out. And that even for someone like me with many areas of privilege and support and expertise in this area, that this is challenging. And that what does that mean for families and for caregivers who may have fewer resources and or be experiencing other challenges that I can't even imagine. One of the reasons that we know that child development is very, very important in these ages is that there is a tremendous amount of brain change happening early in life. And this is a part of what's happening with these milestones, that they keep coming, that they keep happening, and why we would expect them, why babies advance and young children advance so much in very short windows of time, is that their brains are changing, and that when they're not changing in the ways that we would expect, that we may need services and supports to try and help get them back on track, to try and help their development get back into a set of milestones that we think would be typically developing. And that these services and supports can indeed change trajectories for some children involved in these systems. This is a place where we in particular have sought to understand a lot more about brain development and autism. Brain development is not always, or in many ways, something that we can influence. We cannot go into cortical surface area growth and make that happen faster or differently. But there are ways that potentially services like speech therapy, occupational therapy, or other supports through early intervention can help support the brain in getting back up to speed. So monitoring these developmental windows is key. Doing so is challenging. And what does this mean for families where there might be areas of particular disadvantage or service and support needs or societal risk for ways that they may need additional supports? How do we move forward in thinking about what families and babies and young children need? So in monitoring development, part of the issue is that the research base time and time again tells us that consistency across caregivers in monitoring these milestones, documenting these milestones is important. As we think about foster care entry, families where this might be disrupted because a child might have a different caregiver, or they might move, or there may be a traumatic event or something else that happens relative to their foster care entry, that can be further disruptive or exacerbate potential developmental issues for that child or children in a family. Another area that the literature consistently points to is that you have to know these developmental milestones. There are apps for the milestones. They're in the pediatrician's office. They're all over the place for you to see if you're going to those pediatric visits, which can be challenging to get to for some families. We also know that not everyone is going to download an app and monitor their child's development or not understand what to do with information if they notice that there is a developmental delay, that there are gaps across communities. And as someone who was born and raised in a rural area, there are not always ways to easily figure out how to drive 2 hours to get to the early intervention office, or how to get to the pediatrician regularly, or once you get to the pediatrician, how to ask the right questions related to your child's development that can help you figure out if it might be helpful to think about other services to support your child. And that for many communities, there are issues related to stigma or fear of governmental involvement in supporting their child, or that missing a developmental milestone might be due to something related to caregiving. And that could be a fear that families or caregivers are experiencing. And many of these dynamics are complex within any one child, complex within families, and complex when we start to think about involvement of foster care systems. Similar to Medicaid, the number of children who are entering foster care each year is very large. Hundreds of thousands of children each year, that predominantly 1 in 3 of these children are in age 1 to 5, the same key developmental windows that we just saw in that previous slide. However, most foster care systems do not have singular ways to document that children have a disability. So there may be, in Pennsylvania, we have a yes/no indicator in our child welfare system where a child can be flagged for a disability, but there is no other information present related to what the needs of that child are within that disability flag to help us track or understand differences in those trends over time, or ways that additional programs might be needed to meet those needs. There have also been sets of dialogue across the United States about how the opioid epidemic has impacted foster care involvement rates. And there have been many research professionals and professionals on the ground who have sought to document that there were increases in foster care involvement as the opioid epidemic was taking hold in our nation and has continued to grow, and that care and resources allocated to deal with this increase are substantial and are projected also to continue to grow as we think about future years of the opioid epidemic, should it continue at the current pace. So there are a couple of aspects related to the children who enter foster care that are very important for us to think about in the context of intellectual and developmental disabilities. If a child is at risk for not meeting a developmental milestone and they're entering the foster care system, there may be ways that additional screening or intervention points are needed to redirect caregivers for that child to the services and supports, to early intervention, school-based access supports, and other behavioral supports in communities that are needed. We also know from all of the national data that we observe that there are tremendous racial and ethnic disparities related to foster care involvement, and that the reason for these disparities are likely quite nuanced, similar to the differences and disparities documented across rural and urban areas, in that communities look different, that people and families come to the table with different histories related to their values and the ways that they can or cannot access and navigate the communities around them. We know from national data that placements with relatives occur very often in the foster care system and that they have increased in recent years, and that placements change very often, and that rates for placements in general and placement changes vary tremendously by state. There's not been any one consistent documentation of how we think about placement in terms of how we track these metrics that could help us understand how is West Virginia faring in foster care for some of the distinctions related to placement. Many different definitions include that there could be justice system involvement in patient care as a placement. There are also ways that changing caregivers across family members, kinship care, or grandparents are all defined differently in terms of placement. And one place that we may look to for potential advancement and collaborative opportunities could be within the places where we agree on how placements are defined and measured. One area that we are particularly worried about relative to foster care placement and youth with intellectual and developmental disabilities is the aging out process, and that there are differences in ages across states relative to when youth are aging out of the services that they are entitled to through their foster care involvement. This is exacerbated by what we have documented as a service cliff, in particular relative to youth with autism. In the slide earlier, we outlined that many autism-specific Medicaid programs in states end in adolescence or late childhood. And what happens when there is a combined ending of enrollment in Medicaid and access to services and a termination or aging out of a Medicaid program that is focused on autism or intellectual disability, that this may further worsen the service cliff and leave youth, and particularly those in distinct types of placements like potentially incarceration or justice settings, as at risk for being able to access services long-term and be able to achieve stability and insurance and access to care. There's a very interesting report from MACPAC, which is an advisory entity to Congress on all things Medicaid and Medicare, that was focused on therapeutic foster care. And this report, as I was reading it, was mandated by Congress. It was focused on therapeutic foster care as a more intensive foster care model, a way to deliver services, and that 14 states had therapeutic foster care elements in their systems. And what are some of the similarities and differences in how therapeutic foster care is emerging as a model? The report review of these 14 states was very interesting and showed several differences in how therapeutic foster care is being used. By and large, there were higher numbers of youth who were in the 13 to 18 or about to age out age group relative to their younger counterparts. There were also interestingly high rates of use among distinct racial and ethnic populations, including American Indian and Alaska Native groups and Indigenous communities. And that as they looked at the diagnoses or disabilities among the individuals in these groups, that there were higher rates of trauma, so PT, post-traumatic stress disorder, and there was interestingly some larger groups of other or no diagnoses, which begs the question, what are the clinical characteristics of the groups using this very intensive service model? And if or how has it been useful across these groups? Some of the summary points in the report were very interesting. One summation that was made about therapeutic foster care was that there is differences across state Medicaid models that may make a federal initiative to define therapeutic foster care as difficult, maybe interfering. I thought it was interesting that the Committee on Appropriations requested that therapeutic foster care be examined across these states. Appropriations generally thinks about funding and allocation of resources. And is therapeutic foster care, is there particular energy or scrutiny on the use of this model in a way that could yield attention and will to potentially think about changes? So there's a lot of complexity related to how child development interacts with foster care and how Medicaid is present in both services for child development and in foster care, because individuals enrolled in foster care are entitled to enrollment through Medicaid. These dynamics are likely very important for youth with intellectual and developmental disabilities because we can make a difference in their outcomes when we intervene early in life. But doing so, we don't fully understand the best ways to do that yet. The field has not yet taken the tremendous amount of information that we have generated on early childhood and applied it in full to youth with intellectual and developmental disabilities in foster care. There may be new models, albeit therapeutic foster care or something else, that states are using that could help, that might be the kinds of services and supports or delivered in the way that families or caregivers or foster families may need them to be able to facilitate stability in monitoring child development and intervening when developmental milestones are not reached. Okay, now we will get into some data, and I will try and power through a bit. I'm realizing our time. There are several ways that Medicaid data nationally are helpful for thinking about monitoring and measuring foster care involvement. So when we use national Medicaid claims data, we can use diagnosis codes on claims to examine distinct subgroups by diagnosis. We can identify individuals who have an autism diagnosis and look at them and their patterns in access and use of care over time. We can also see in some of the billing detail access to other insurers. Some children enter foster care even when they have had private insurance previously or have it in tandem. We also, in some cases, are able to link up data from across data sources. So we can look at, on our team, Medicaid linked to children in foster care on Medicaid linked to, for example, housing supports from HUD. We can also look at community characteristics. We can use measures like the Area Deprivation Index or the Child Opportunity Index to examine what's happening around children so that we can understand where there might be distinct opportunities or challenges in the aspects of their development that are needed. We can also look at individuals over time. We have a lot of headaches, however, when we look to use these data sources. So accessing these data has extensive time. You need a tremendous amount of funding and permissions to buy it. That linkages across sources can be limited. So when we don't have things like social security numbers or other distinct identifiers, and we're linking by name, sex, date of birth, that can be really challenging to do accurately. Also, insurance data lag, typically by up to a year, which delays our ability to understand what's going on real time and can be frustrating for thinking about change. And administrative data do not report on what individuals are self-experiencing. What are they happy with distinct services or outcomes or not? AFCARS is a foster care data source available in states that tracks foster care involvement, but is not currently linked to Medicaid at the federal level and can only be used as states are working to combine their data themselves. And more that you all can probably think of too. For many reasons, autism and intellectual disability are also very helpful to compare. Autism has a very recent prevalence increase. Over the last 2 decades, the prevalence has increased exponentially, and that we know this is very different from decades of advocacy for the intellectual disability community, that this results in a certain bolus of attention to autism, whereas pathways for intellectual disability programs have existed for a longer period of time. There are different characteristics of state Medicaid mechanisms. So most autism-specific programs are for early childhood. In Pennsylvania, we have 2 of the only adult-specific autism programs in the nation. One is a 1915 C waiver, another is a managed care program that's operating in 4 counties. We also know that autism presents as a heterogeneous spectrum, that there are many differences across individuals and within individuals over time. Whereas there are IQ thresholds generally for individuals with intellectual disability. We have very few tools to think about needs or clinical characteristics of autistic individuals, especially in adolescence or adulthood. Whereas for individuals with intellectual disability, there is a better, although not perfect, set of research that has helped to generate these tools. In Pennsylvania, one of the first questions that we got as the autism prevalence was growing exponentially in the early 2000s was how many people are there in our state? And so we conducted an administrative prevalence, which is we combined data sources originally for 2009, a 2009 report from our Department of Public Welfare, which houses our Medicaid program, and education. And we found about 19,000 people. When we updated this Pennsylvania autism census in 2014, using data from 2011, we added an array of other sources. We were also able to add in distinct data from our child welfare entity in Pennsylvania, which allowed us to look at the state level at youth with autism specifically in the foster care system. So for me, among the most important points that emerged from this report was not only that our number of autistic individuals in Pennsylvania had nearly tripled, it was also that we found about 1,500 children with autism in Pennsylvania in 2011 alone. It's 13 years ago. That number has likely increased. And perhaps most importantly, fewer than half of these children were flagged as having a disability of any kind. So although we saw service use and needs in the Medicaid system, our child welfare system did not have a disability indicator that was bringing forward the same disability information. And are there opportunities for how this gap in understanding the characteristics of these children could better support meeting their milestones, helping to generate connections to services and supports? Some of our most recent child welfare data in Pennsylvania indicates that there are still major issues. There are still fatalities, there are suspected near fatalities, and ongoing issues related to child abuse, whereby if we understood the clinical characteristics of subgroups in this system, we may be able to facilitate better linkages to services and supports for children and for families. We know of probably 5 or 6 other states that have sought to combine or understand their child welfare data by examining distinct clinical subgroups. However, these are generally disconnected from each other. And if there were ways, as one idea, for us to be learning from each other and understanding these differences, it could be particularly helpful for how we move forward. So I'm going to breeze through some federal data. This is a paper that was published using federal Medicaid claims data, looking at the prevalence of autism in the foster care system. And there was an increase in the prevalence across 2001 to 2007. This is right when the autism prevalence nationally was also increasing. They also saw some interesting things related to the autism and intellectual disability groups relative to other foster care enrollees. So in general, the prevalence of autism is more male than female. We see that here in these records. Reductions in the proportion who are Hispanic or Latine, but increases in individuals who had an other race or ethnicity. And the autism and ID group was more stable in their enrollment in Medicaid. So as these researchers sought to put together all the people and all their time enrolled in Medicaid, they saw elevated odds for enrollment in foster care among the autism and intellectual disability groups. Some racial and ethnic groups had lower risk for foster care. And are there ways that we need to do better about identifying these groups? Because there is no reason why we would see differences, in particular in autism prevalence, due to race or ethnicity, based on bodies, based on human development, that all of the lags are based on the ways we identify it. This research concluded by saying autism is at high risk for entry and posed the question of services that need to be generated that states could make available. And I think that a part of what may have been missed here was that there needs to be ways to fund those services, to reorganize systems, to make those services available, and that this is a much bigger lift than perhaps we have yet to acknowledge. We saw it in a paper that was published last year to update this information and to look at differences among foster care enrollees with IDD. Right here on this slide, you can see a snapshot of the variables that we use in our national Medicaid data to distinguish groups of foster care enrollees. So there's children with Title IV-E, adoption assistance, foster care or guardianship care. Then there is a different eligibility code for former foster care children and a different eligibility code for independent foster care adolescents. For our research for this paper, we used only the children with Title IV-E adoption assistance, foster care, or guardianship care. We found a couple of overarching themes as we looked at this group. First, it had grown. So it had grown tremendously. And we found that the IDD group was older than the non-IDD group, which is interesting, related to how this group may persist in the foster care system differently than youth that may transition out of the foster care system. There are also many females with IDD in the US foster care system, and that this is a group that in the autism field is particularly lacking in terms of research where we have an emphasis on understanding their services and support needs. We also examined differences across sex and race ethnicity and found that there were distinct differences related to higher rates of enrollment among Black or African American communities and lower rates of enrollment in other racial and ethnic groups. Logistic regression models help us to look at risk for involvement. And what we can see here is that the autism and the intellectual disability and the combined groups all had elevated risk for enrollment in foster care relative to their counterparts without these diagnoses, and that females had higher risk for foster care involvement. As we looked at race and ethnicity, we saw reduced risk for Asian or Pacific Islander groups. We saw increased risk for Black or African American groups, and the rest of the groups we were not able to establish statistically significant estimates. So we landed on pushing for more, and the equity in these areas is desperately needed for us to understand places where we can intervene in the system. So we have some newer data for 2019. The data I showed you from the paper was from 2016, and we sought to capture the new estimates. And I don't know if this number looks right. One of the things I was hoping to do today was to get feedback on if this number looks about in alignment with the numbers you all would expect in West Virginia. I would also note, however, that as we've updated this data for this presentation, these numbers are not final output ready for broader release. However, we are seeing tremendous growth. So an additional 19,000 individuals enrolled in the US foster care system from when we looked at this number just 3 years prior. So we built some comparisons across groups for all other states compared to West Virginia. And we do see differences that align generally with the demographics of West Virginia. There are also some differences related to age groups, whereby the West Virginia population is fairly consistently a little older in some of the categories than some of their counterparts in other states. And we sought to look at risk using, again, a logistic regression model, whereby we see a continued evidence for increased risk for females, increased risk for Black or African American populations, and reduced risk for Hispanic or Latina populations. We also see the elevated risk for females in the West Virginia data and see reduced risk in the older ages in the 18 to 21 window in West Virginia as well. So we're excited about finding differences that matter for a journal. I think the question is, how do these differences matter for what you all do every day, what you do on the ground, and what can and should we do next to be able to move forward the system? Part of this and the lessons that I've learned are that these partnerships are among the most difficult in those that I work with. There are big ways that even disciplines that look and sound pretty similar, like social work and public health, really think pretty differently about what are the priorities and how do we address them, in what order, who do we talk to, and how do we proceed? And that has been very, very challenging for how we advance this work, but something that we're dedicated to moving forward. That much of our own values related to using this data is anchored in the idea that these are data that belong to the communities that have generated them. And that includes all of you on the ground who are serving and supporting the foster care system every day. And that engaging with you and understanding the ways that we can document and understand opportunities for change is a critical part of how we think about next steps. In Pennsylvania, there have been some very interesting conversations about the intersection of foster care and, for example, medically complex children and ways that we might be able to target this group to move forward. And Pennsylvania has an initiative focused on medically complex children broadly, but hopefully the attention to foster care children in the system will be a target too. And there are very interesting emerging models related to managed care in the Medicaid system in comparison or contrast to fee-for-service programs within Medicaid and how we set up and structure services for youth in foster care that are important for us to track in terms of what is working and in what way and how. There are also several, I searched in our national database of federally funded research and found several very exciting studies that have been recently funded or are underway, including trauma-informed sleep interventions for youth in the foster care system. Seems like these are exceptionally valuable interventions to support foster care families, to support the families who are taking care of these children, and children who are transitioning back to families for unification as well. Linkages to other insurers are key for us to understand the full picture of what families are navigating. And I found some interesting resources. Even in Philadelphia, we have a data bank of resources for foster care families, including abilities to link to training specific to disabilities for families who have children with diagnoses before their children can return to the family. I apologize that I overshot my time a little bit and powered through the data elements here. I'll put this link back up with my contact information, but first pause to thank you all for having me. Thank you so much. It was great to look at West Virginia data. I hope this was interesting and useful. Thank you to my colleagues, Chisa Merriweather and Jonas Ventimiglia, who really helped this presentation come to life, all of our team members and our funders as well.
Thank you so much, Dr. Shea. I think that that was really helpful and really interesting to see the growth and the change and the way that the data can be looked at to suggest things across different programs and different audiences. I know we have a lot of people on here from a variety of different backgrounds. So anybody have any questions or comments or thoughts to share with Dr. Shea? Don't be shy, just go ahead and unmute.
Yeah, thank you, Dr. Shea. This is Steve Brady. I'm with the IDD state programs. And, and I know that Medicaid is the big major funder for most everything. But with our waivers in West Virginia, I don't know if you're aware or not, is the most stringent in the country. We use a 3 standard deviation to determine eligibility for IDD. And then autism, if it's just autism, it has to be a level 3, not 1 or 2. And that, and one thing I have noticed was I look at all the people that get approved for waiver, then get put on a wait list, and our office contacts them all to try to link them up with services and programs. But I found out when I did my own research in 2023, we had over 61% of the people that were approved for the IDD waiver either had an autism diagnosis or an autism IDD diagnosis. 2 or 3 years prior to that, it was like 41%. So it almost increased 50% in that short amount of time.
Wow. I think these are exactly the nuances that matter in terms of how do you think about connectedness for level 1 or level 2 autism youth who might still need services and supports, and are there options? Is, in some of our work in Pennsylvania, we have a warm line collaborative statewide to try and get families somewhere, and that this community mapping can help families at least get a foothold in connecting to other families who've navigated it and sought to find ways. I don't know also, Steve, if there's a difference once they enter school. There have been a couple of Medicaid initiatives related to reinforcing the ability to provide supports in schools. And I don't know if you see, or if West Virginia has a different approach when it comes to school-based services, or if you experience it similar to the Medicaid system in terms of constraints.
Well, I know they do have a serious emotional waiver that may be a crossover for that. I've been an advocate to try to get an autism waiver so they can get some intensive services. I mean, my view was to get intensive services between 3 and my thinking is 16, so then get through puberty. And then if they're still qualify for the IDD waiver, they just kind of roll over to it, but it
Yeah.
hasn't picked up any friction yet.
Political will. I hear you. I think that that's a place where I'm extremely interested in how our data could be a support. We have documented and have other researchers have documented how when you generate and provide community-based supports, you are avoiding higher rates of ER-based care. You are, supporting improved long-term trajectories. That message does not always yield political will for waiver slots or changes in waiver eligibility criteria. And maybe you have a better idea. I think that those of you who are navigating this on the ground really, I learn so much every time I talk to people like you all that I'm seeing here in terms of all the contacts in the chat around what would be helpful. And it's so different from what I or what any other researcher I talked to thought would be helpful, that it feels like we just have to stop and ask the questions before we just keep steamrolling this to try and do it better. So Steve, welcome any sidebars in terms of, if you have thoughts or ideas there. Even in our state, which I would say does have a very different political climate, I don't get a whole lot I don't know that there's a lot of yes, let's change all the criteria to open everything up. I think that there's a distinct awareness of the resources that would take. It's not nothing.
Right. I mean, I just know on the adult side on autism, without proper support at a young age, they're the ones with the more extreme behavior, and also they end up going to the state hospital for a longer period of time because they hadn't had the support at such an early age.
Yep, absolutely. Which incurs a cost too.
That also makes me think about the proportion of children aging out of foster care that have these diagnoses. And so if we're already seeing a higher prevalence in adults with autism being admitted into these long-term care because of different reasons and lack of supports, then, you just have to wonder or imagine that those that are aging out of foster care on their own would be even higher.
I also think that there's a particular lack of attention to rural areas and how we navigate these issues. And I understand why, a lot of what we hear about from cities is so compelling and important for us to understand and learn from, but the families also navigating these rural areas and how to deal with all of this to get where they need to go, I think is a place where a tremendous amount of time, attention, research, collaboration is needed. And, I really just appreciate all of you showing up today. I realize you have incredibly important jobs that make differences in lives all the time. And for you to, take an hour to be here to watch this wherever you are, and, if to any extent reach out and be willing to talk about collaborations or ways that, we could do better. I really am deeply committed to that and grateful.
We're getting close on time, but I wanted to ask, does anybody else have any other questions that they'd like to ask Dr. Shea before we wrap up today? There's one in the chat asking, thank you. Will there be reference resources available? Is that something that you can provide us so that way we can add it to the archive for this?
Absolutely. I cited my sources throughout the presentation, so they're on the slides, but I'm happy to also provide direct links, also copies of our publication in JAMA Pediatrics, if that's helpful. Whatever references are of interest, I'm happy to make sure you get them.
Great. And then my last question is, are there any states that you have seen that are just doing it really well that we should examine closer to see what they're doing and how could that be replicated?
Yeah, there was you know, this is not specific to the foster care system, but I think applies. There was an initiative in Massachusetts and an ongoing conversation from their children's mental health campaign related to state service system structure and talking about, you know, do you build one front door and then have somehow specialties wrap around the kid, or do you have all the specialties and the kid comes in and has to access them? And they had talked about some of the New Jersey structure in terms of you know, the way that I heard it articulated was, you know, doing a good job of helping kids to get in a front door and then have access to many different systems all at once, rather than even in Pennsylvania, we have many different systems that you have to access into solo. The foster care system is not per se interwoven with our IDD system in a way they communicate all of the time. So I think that some of these single front door models are really, really interesting. I don't know what they look like on the ground. If a family coming in and then you get assigned a person to try and help you navigate across these areas. I've seen parent and you know, peer support models that work really well, and then I've seen some that are problematic. So I think these are all the questions. Much of it has to get back into what your state's willing to do, though. I think, you know, to Steve's point, there's just there's a political undertone here that we all have to be understanding and responsive to, because that's the metric from which change will be measured. And that can be hard to digest. That can be exciting. It depends, I think, a bit on where you
Thank you. I know I'm interested myself in looking at some of the data that you had shared, the article related to the training of the foster care families. So I think that that's one area for sure that could be expanded related to how to better serve children with disabilities who are in the foster care system. So I'm very interested in that. And thank you very much for joining us today and sharing this information. Thank you so much to everyone who are attending. If anyone would like to receive a certificate of attendance to submit for personal credits, go ahead and put your name and email address in the chat now. And Dr. Cottrell will try to get that to you within the next few days. Thank you guys so much for joining us, and give us a few days. This will be on our website archived, so you can come back and reference it, share it with others, let people know, hey, you missed a great presentation. All right. Thank you so much, Dr. Shea. Thank you for everyone. You guys have a good day.
are. Bye.
Bye.